Is Colorectal Cancer Awareness Month, and each year we do a month's worth of segments on this very common cancer that maybe a lot of people don't pay all that much attention to. We want to change that with our conversations with our friends from Indiana Regional Medical Center. And Dr. Dan Clark joins us this morning. Our conversation brought to you by Marcus & Mack, voted best personal injury law firm in the Best of Indiana County contest. Marcus & Mack, a law firm representing injured people. Good morning to you.
Good morning. How are you?
Wonderful. It's been a while since we've had you in the studio, so it's good to catch up with you again on a very important topic. And it puzzles us sometimes that people don't pay enough attention to colorectal cancer and how beatable it is as a disease. But it really is, and as common as it is, it's something we should all pay attention to.
Right, and as you say, it's as common as it is. It's the third most common cancer in both men and women. In women, it's breast number one, lung number two, unfortunately still from smoking, and number three is colorectal. And in men, it's prostate, followed by lung, and then colorectal cancer.
Yeah, so those are big issues. And colorectal cancer, when we use the term beatable, curable is another word that gets thrown out at that time. But really, when you consider the options that are available to us in terms of preventing colorectal cancer, they're pretty stellar.
Yes. I mean, if we follow the recommended screening guidelines, then you can pick up cancers before they're cancers at the polyp level and remove them before they have a chance to turn into a colon cancer.
Yeah. Is that the only way that people get colorectal cancer is through polyps?
Well, no, there are different ways to get colon cancer. And, there are some genetic syndromes that you can get colon cancer without having polyps. They're, however, fairly rare. As you know, I do the genetic testing for colorectal cancer. But the genetics actually comprise less than 10% of all colorectal cancers. So the vast majority of them do come through polyps.
All right. So that makes the screening extra important. I want to get this out there right away. There is an event coming up on Monday at the Hilton Garden Inn. You'll be there. Dr. Billum will be there. I believe Dr. Billamoria and Dr. Guidetti will be there, too.
Yes. Yeah.
Yeah. Well, it's big time getting all the heavy hitters out.
Right. An even bigger heavy hitter. We will have the Da Vinci Xi surgical robot there.
Wow.
And so, we're having that there, so you can come and actually hop on the robot and see the benefits of the robot, get to try it out, pilot the surgical robot.
We get to drive it, huh?
Yep. Sure can.
Well, how about that? That guy I know is really, really busy, so to get him out of the OR.
Well, it's not ours. Ours doesn't leave the OR.
Okay.
Ours stays in the sterile environment in the operating room. This is a Intuitive company who makes the Da Vinci robot. They have a traveling robot. And it's, the exact same prototype that we use in the operating room. So you get to actually sit down on it and see the benefits from the 3D vision. Then when we put your eyes down in and use the robotic arms and see the wristed instrumentation and things like that.
Yeah. So at the event coming up on Monday, by the way, it's at 6 p.m. You can go to irmc.org/2023, and that's how you register to go to this event. People are actually going to get to take a spin on the robot, but they're going to get the information that you really need to have about colorectal cancer. That's the important thing.
Right. We'll give a presentation on colorectal cancer and on the robotic surgery for colorectal cancer as well. So,
yeah. All right. So let's talk a little bit first about screening for colorectal cancer and the colonoscopy that is so important.
Right. And people, tend to not like to have the colonoscopy. The biggest part they hate about is the prep, because you have to have a clean colon for the colonoscopy to be able to see polyps. So we have to prep the colon. You have to drink that stuff that gives you the runs and cleans out your colon. The other tests just aren't as accurate. The old fecal occult blood tests where you do a chemical test to the stool. Either the doctor sends you home with the cards and you send them back in, or they do the finger wave exam in the office and test the stool. That's a chemical test looking for blood in the stool. And that's what we had for many years. And that would miss a lot because diet can affect that. So you have to be on a certain type of diet because, spinach can increase the iron in your stool and things like that. So that was really affected by a lot of dietary changes. And even if you have a polyp, they only intermittently bleed. And so it may not catch them.
Yeah, yeah. But the colonoscopy, that is a scope that actually goes inside your colon and searches out in very minute detail and finds those polyps, and the doctors then remove them at that time.
Right. It's a very high def. Those scopes have come a long way. It's a very high def camera that goes up through the colon after you're cleansed out, and we look at the lining of the colon, can pick up very small polyps. And like say, if we see a polyp, you can actually remove them at that time and prevent them from becoming cancer. And that is the most sensitive test.
Yeah, and so that makes it really, really important to have that done. How often and at what age should we start thinking about that?
Well, the age is the big thing. We've seen actually a decline in the number of colorectal cancer incidences over the age of 50, but unfortunately, we've seen an increase in the incidence of colorectal cancer between the ages of 20 and 50. So we're seeing more young people with colon cancer nowadays. It's still far more common once you're over the age of 50, but it has increased dramatically in the younger ages. So the American Cancer Society a few years back decreased the age recommended to start colonoscopies. It used to be 50 if you had average risk. Now it's 45. So it's recommended that if you have average risk, which means no family history of colon cancer, no personal history of polyps, no prior radiation to your belly, such as for pelvic cancers or things like that, then the average risk person should have a colonoscopy at age 45 now.
Yeah, yeah, and that's a significant change.
Right. Yeah, and because I'm sure everybody out there knows somebody who was in their 40s, and I've had several patients in their 30s, with colon cancer.
Yeah.
And we're seeing it younger and younger now, unfortunately. And we actually don't really know the reason why that's happening. Mm-hmm. It's definitely something environmental. And so, because the genetics haven't changed. And so why are we seeing younger and younger cancers? And we don't have a good answer for that right now.
Yeah. All right. So if that doesn't get done, and unfortunately you do develop colon cancer, what are the symptoms that people should look for? And are the symptoms readily apparent?
No, they're not. That's the problem. We talk about GI upset. Well, who doesn't get GI upset intermittently?
Mm-hmm.
Blood in the stool is the big one. If you see a change in the color of your stool to a very dark color, that could be a cancer from the right side of your colon, because the blood gets processed and then it's the iron in the stool and it causes a darker, blackish looking color to your stool. Of course, if you see bright blood in your colon, don't assume it's from hemorrhoids. That's the classic mistake. Oh, I have hemorrhoids. Well, the hemorrhoids may be secondary to what's going on above there. Mm-hmm. And the other thing is a change in the size or caliber of your stool. If you go from having normal stools and now they're flat, or pencil-like, that's pretty advanced when they get pencil-like. But if you notice that they've gone to flat or anything like that, and overall just a change in your bowel habits, without a change in your diet or anything like that, all of a sudden there's been a change in your bowel habits. Those are the concerning signs.
So those are big signs that there might be a problem, and then once you have determined that there might be a problem, you need to get in touch with the doctor. You need to get it taken care of. Don't wait.
Right.
Yeah.
And the big thing is now the people want to avoid having colonoscopies, and so there's newer tests out there. So if you have a colonoscopy at age 45, the recommendation is 10 years, if you're average risk. So it's not like you have to have them every year, mm-hmm. If you're average risk. Now, if you have a higher risk for family history or whatever the incidents are, we'll customize the recommendations. So.
Sure. But generally, once you get that first one done, that establishes the baseline for you, and you ought to be good for a number of years.
Right.
Yeah.
So.
All right. Colon cancer and mortality rates, obviously very concerning.
Right. Again, it's the third common cause of cancer deaths. It's the third most common cancer, and it's the third most common cause of cancer deaths in this country. And it is totally preventable, by doing the colonoscopies. And, if people, for whatever reason, can't get a colonoscopy done, at least doing one of the other tests intermittently as well. The problem with the other tests is if they're positive, guess what you need? You need a colonoscopy.
Yeah.
Because the colonoscopy is one. But we can prevent it, and it is the third most common cause of cancer deaths in this country.
Now, we're going to have you back later this month. We're also going to have Dr. Billen come and maybe somebody else as well as we talk about colon cancer and its treatment and the surgeries for them. But in general, are most colon surgeries now done robotically at IRMC?
Yes, pretty much all of them are done robotically at IRMC. And, it used to be you'd be in the hospital anywhere from 7 days to 2 weeks after an open colon surgery. Now you're home between 1 to 3 days, and it's four little small incisions, very little pain afterwards. And, we can start feeding you right away after surgery, because with robotics, your bowels don't shut down. You don't have the pain that you do with open surgeries. You can get up and walk around right away. We start feeding you liquids the night of your surgery. And if you tolerate that, it's a pretty rapid advance to a regular diet and home.
Less likelihood of infection as well with robotics? Would I be correct in saying that?
Correct. Smaller incision equals smaller risk of infection in the wound and everything. It's more precise because we can see better. We have wristed instruments, so we can do all types of suturing inside. But we can magnify things up. It's high-def 3D vision that we can magnify up to 10 times normal vision. Yeah. So small structures look big, and we can suture them more easily as a result.
So the event coming up on Monday, we'll get that information in much more detail from all of you who are there representing IRMC. It's at the Hilton Garden Inn, and it's at 6 p.m. on Monday, and you need to go to irmc.org/2023 in order to register for the event, and you promise to make it fun.
Absolutely. Well, it's fun. You just get to drive the robot, so that's pretty fun.
There you go.
I think it's fun, and I do it all the time. So,
Well, sure. Yeah, we get to be our own little doctors there. I was saying on the air the other day, I imagined it's sort of like the game of Operation when we were kids, or where you used to pull out the funny bone and stuff like that with the tweezers.
Right.
It might be slightly more sophisticated than that.
A little more sophisticated than that.
Yeah.
There's no tremor. There's no, trying to get you. You're much more precise than that.
No red light bulb for the nose either.
That's right.
On the patient.
No bulb that comes up.
Other than that, almost the exact same thing.
Almost.
Dr. Dan Clark, thanks for being with us today. We appreciate it. Now, anything else you need to pass along to folks?
One other thing they wanted me to talk about is that, there's a new initiative between IUP and IRMC, the Rural Podcasts.
Oh, yeah.
And this month, I'm happy to say it's my Rural Podcast. Jim Kinnear, who runs the podcast with IUP, interviewed me about robotics in the rural hospital setting. And so it's on, I have to look down here, irmc.org/pulse. And that's the Rural Podcast. There's also podcasts about our new residency program that you can click on. This month, the one that was just released is about robotic surgery at IRMC. So you can click on there and listen to the podcast as well.
Apropos, isn't it?
Right.
Excellent. Well, thank you so much for coming in today. We'll catch up with you again later in the month.
Sounds good.
He's Dr. Dan Clark. It is the voice of Indiana County. It's WCCS 101.1 FM and AM 1160. Approaching the 9:25 mark and CBS Sports Minute. And then Jake is back with us in the WCCS newsroom. Indiana in the Morning, as always, is presented by First Commonwealth Bank. The CBS Sports Minute next, and it is presented by S&T Bank. Relationship banking, one customer at a time.
At S&T Bank, our team offers personalized advice and individualized solutions to